CLSI guidelines, antimicrobial policy, and a journey to implementation of stewardship. See, there are three important terminologies here: guideline, policy, and stewardship. This is just a beginning to say when we thought of conquering the world of microbes, and number of antibiotics were produced, and this just gives you a bird's eye view of different antibiotics that were synthesized or got from the natural sources, later on synthesized, and this is followed by their introduction into the population. First we had the sulfonamides, but penicillin was the first antibiotic to be introduced as an antibiotic from Penicillium notatum, a fungal organism from where penicillin came. Most of the antibiotics we are getting it from the fungal and other bacterial sources. We do get it, and these are the dawn of antimicrobials from 1904 to 1942, followed by the golden era where a lot of use was there, and we thought of conquering the microbial world and saving and living safe. The rise of antimicrobial resistance started noted. It was noted first in 1976, and that continues to be there. So, before I go into my topic, I would like to give a guidelines, the definitions of these three terminologies. Guidelines are a piece of information that suggests how something should be done. It's a general rule or a principle or piece of advice that one has to follow in formulating or using a drug. So this is a very important thing, and CLSI has been very helpful for us in actually making our policies and procedures for the treatment of infectious diseases, and a course of principal action adapted and processed by an organism or an individual is called as a policy. Policy is course or a principle of action adapted and or proposed by the organization or individual. So policy is to be individual. It's an organizational property, and you can't be following the guidelines for setting up any policy for your organization to go through, or you think of a national level organization policy for antibiotic cannot be prepared, because each part of us are working in different areas, and the policies have to be done locally. Then stewardship, it is a practice committed to ethical value that embodies the responsible planning and management of resources. Concepts of stewardship can be seen when I talk the whole thing, that is the journey which I took in PES Institute of Medical Sciences and Research in Kuppam, a rural medical college where I work at present as an Emeritus professor in the Department of Microbiology. So, coming to guidelines, CLSI performance of standard is CLSI 100 is the main source from which we get all our resources of direction of how to use, on which organisms to use, what are the interactions, what is the dynamics, what is the kinetics of the antibiotics that each one of them have. All these things are dealt with, and that gives the is an annual publication that is coming out. The present one of 2024 is the 34th edition, and it is supported by other supportive documents like M02, M07, M11 and supplement S23. These are additional information giving things. Each of them actually describe how to perform the antibiotic sensitively in vitro, and for gram positive, gram negative, or for the anaerobic organisms, how we have to process and come to a conclusion of identifying the susceptibility of different organisms. It is published annually by the Clinical and Laboratory Standard Institute of USA, a non-profit organization. It is a dynamic document because every year CLSI comes out with a new edition of these guidelines, and they form the basis for all the microbiologists around the world to follow and make their policies and stewardship programs. So what is the role of WHO? What does WHO say about the use of antibiotics? They brought in a new terminology called as, you classify the antibiotics and don't see, it's more than 25 years now that the last antibiotic was actually invented, and afterwards subsequently there are no antibiotics that have been produced by any of the pharmaceutical company, and so we have to use rationally the antibiotics. So they brought in a term called as access. A stands for access, then W stands for weight, and RE for reserve. So you have to classify your antibiotic before you produce your policy for the institution, so that we conserve the antibiotics for treating either complicated case, either a multi-drug resistant case, and try to see that we preserve the antibiotics for the future generations to come. So CLSI guidelines gives us the details of pharmacokinetics, dynamics, and bioavailability of different antibiotics in clinical specimens. That is, it may be different for different tissues, and to target the organisms, these are very, very important things that we have to consider, and we have to use judiciously the particular antibiotic. You can't be using a drug antibiotic which is metabolized in the liver for any liver infection. Similarly, a drug that is passed through in our stools cannot be used for gastrointestinal ailments. And these are all the things that are taught in medical schools, and that's how we try to see that we use proper antibiotics. In addition, it also gives details of antibiotic action, interactions between antibiotics, and things like that. Basically gives zone size of antibiotic testing and its interpretation. So it is a comprehensive guideline, and that's how it has become internationally viable, important, and followed throughout the world. So basically, the antibiotics can be classified as those that act on the gram-positive or a gram-negative or anaerobic organisms. But we also have major organisms, organism-wise, we can also classify them. At the same time, bioavailability in different tissues. And just skip through in a rapid manner without going through individually, because for Staphylococcus species, you have this number of antibiotics. Enterococcus, you have got the next group of organisms. Then Enterobacterius, Bacteria family, gram-negative organisms, you have certain restricted antibiotics. Then for Pseudomonas aeruginosa, which usually comes from environment and infects human beings or animals, that is the other group of organisms are there. Antibiotics are there. And lastly, they are also given the group of antibiotics that are important for Acinetobacter. Acinetobacter is a major hospital-acquired infection. That is actually a iatrogenic cause. That is, we inadvertently use the antibiotics in an irrational manner. Prescriptions are given, and the Acinetobacter species, they become the causative organisms for many diseases. So the urinary tract infection, whenever the urinary tract infections are there, these are the antibiotics that have to be used. Similarly, for stool sample, CSF, and other things. Similarly, we have got for the blood. One more slide was there. Let me see. Yeah, blood, sputum, pus isolates. We have the other antibiotic for the similar group of organisms, and we have the stool sample, CSF sample, and drugs to be not administered in pregnancy. These are the way the antibiotics are classified for actually preparing our policy for our institution. So these are basically helpful in the selection of antibiotics for different infections based on the organisms involved, and taking the institution antibiotic sensitivity pattern. The antibiotics have to be classified, and you have to work out the percentage of sensitive cases out of the total that for each of the isolate that you have got, and try to find out what are the diseases that you are commonly coming across in the hospital. They are actually put into different departments. Department wise, you actually distribute the antibiotic, and what is important there we have to take from the previous table and try to give depending upon the percentage of clearance of the organism that takes place. So that helps you to finally prepare the entire policy for the hospital. For a successful antibiotic policy implementation, certain general rules are there. Not to use antibiotics for viral infections or when there is no infection detected. You have to avoid using the thing. Then use monotherapy. Then avoid use of combinations. Rationalize the use of antibiotic based on the antibiogram of the institution and try to use them. Then avoid using higher antibiotic to start with. Yes, this is a problem that usually comes with new intensive care units that are coming up. Patient directly lands up after a window shopping with so many medical institutions outside, and he lands up with a tertiary or a quaternary care hospital, and has already got exposed to many of the antibiotics, and he has developed multi-drug resistance. Complications are there, and you may have to use higher level antibiotics. So as such, for normal cases, not to start higher antibiotic. Use of the above guidelines to arrive at the use of proper antibiotic of choice for using empirically. Empirically is for routine use, you have to classify, and that is what is a policy talks about. Policy basically talks of empirical treatment and also restricts to certain high risk areas of the hospital, like the intensive care unit, high definition units, then CCU, cardiac ICUs, then you have got the nephro ICU, bone marrow transplant units, infant, that is neonatal and pediatric ICUs, where you have to make special policies that have to be actually mentioned in the policy document of the institution. Then you have to rotate the antibiotics to prevent the rapid development of resistance that could occur. So you have to make first line, second line antibiotics from the antibiogram of your hospital, and try to actually rotate it so that once in 2 years you rotate the antibiotic, so that the same antibiotic is not continued for longer period for the organisms to develop higher level antibiotics and resistance. Then reserve some of the antibiotic to be used for severe and multi-drug resistant cases. And sometimes when it is out of control, we may have to think of giving holiday to the antibiotic. So holiday, antibiotic holiday is another mechanism by which you can revert back the sensitivity of the organisms to a particular antibiotic. So I have coming to my own institution. I have done the antibiotic. So WHO criteria of access, weight and reserve are kept in mind, and category and antibiotics selected. We know the organisms that usually infect bloodstream, so we have the things, and we try to place the antibiotics based on the sensitivity pattern, and the highest level of sensitivity that is there, we reserve it. Here beyond the reserve I have put as cholesterol. We don't want to give cholesterol for any case for that matter until unless the patient is severely diseased and there is no other way, he has got multi-drug resistance, then we try to use cholesterol and save the life of the patient. For each of them, I have also given on the other side remarks column some of the important things like gentamicin, then ceftazidime, clavulanic acid combination, piperacillin, tazobactam combinations. These are the way that we try to make and guide the clinician to see that the antibiotics are properly utilized. Similarly, next for the after blood, body fluids, we have got
I think you'll have to
yes sir.
Really.
Yeah. Next for the pus, we have got the same thing. Then sputum, then urinary tract infection. So this is how enterococcus infection is very important. Again, a hospital-acquired infections are very common with this. So how do you reserve is being done here. Then for gram-positive staphylococcal aureus, we have got, and those which have got methicillin resistance, we have got the antibiotics on the right-hand side are categorized and try to do the thing for the thing. Restricted use of higher level antibiotics bring the stringent, that is nothing but the stewardship. Here bring the stringent restriction on prescription practices. Pros and cons of higher antibiotics have to be described as per the clinical condition of the patient. So proper escalation, de-escalations of the antibiotics are practiced, and advice is basically given by microbiologists based on the cultures, and he interprets and he sits and discusses as a team event along with the treating clinicians. So decision is a collective action, collective decision of clinician who is treating the patient and the microbiologist who advises the use of antibiotics. So a clinical case, I just go through the whole thing, how the microbiologist, I have show the examples. So 2 workups of the antibiotic stewardship, and this is whatever is discussed is documented, and it is put in the case sheet of the patient so that the document is available for future reference, and who has actually given the thing, and afterwards you have to do the evaluations. Then there are tools of evaluation, or you have got the top to bottom evaluation, that is from the prescription to the that is pharmacy. You go to the pharmacy is a from end, that is a bottom up procedure, and top bottom is already prescriptions have been given by the clinician and it has been prescribed, and patient comes to the pharmacy and picks up the antibiotic. There's a tool that we can use it, and each have got their own pros and cons. Why are we discussing this topic of antibiotic in this conference is antibiotic is not only used for the treatment of human infections but also by veterinary infections. Then disparity of dose and course of infections. Plenty of animals are there with different body weights, few grams to few kilograms. The body weight of the animals are there, and many a times veterinarians may find it difficult to advise or give antibiotics, and culling is what is practiced in the thing. Nanotechnology would help us to reduce the dose of the antibiotic, and that may be the next thing. The other problem that is coming, and we are discussing this because antibiotics have entered the food cycle of all animals and all living beings. Food cycle involves antibiotics. Antibiotics are getting mixed up with the environment through excreta of humans and animals. So usage purpose, different species specialities are involved to prevent delay in development of antibiotic resistance. It has to be done in a conference like this, would actually take the message to each and everyone around the world to preserve antibiotics for future, so that we are still able to actually fight against the microorganisms which infect us. So recently one guideline of wastewater and solid waste management for manufacture of antibiotics was given by WHO in 2024. Recently it has been released. And this is what in the process they have done. It's a too crowded one. And I would like to actually put this slide at the end. Paul Ehrlich was a Nobel laureate. He told drug resistance follows the drug like a faithful shadow. So newer the antibiotic that comes, antibiotic resistance is going to follow, and so we have to be prepared and fight against the microorganisms and see that we preserve them for the future. Thank you very much. I thank the organizer for giving the opportunity for putting up these things, and what is done in medical field I have put it up, and here is a place where experts from different fields have come up, and they can always have a discussion. We can come together, and this has actually given a very nice platform for all of us to come together and discuss about the future of antibiotics. Thank you very much.
Thank you, sir.